3, 2, 1. And we're live.
Bore yn croeso i'r gyfarfod bodd iechyd prifysgol Cymtar Morgannwg. Hoffwn arestyn croeso cynnes i bawb sy'n gwylio heddiw. Good morning and welcome to the bi-monthly meeting of Cymtar Morgannwg University Health Board, which is being held in public. We are broadcasting today's meeting of the board live, and I would like to extend a very warm welcome to all those who may be observing the meeting today, both in person and virtually. Just to remind colleagues that a copy of the video of the meeting will be available following our meeting on the website for those who wish to view it. Just some quick practical points this morning. Just to remind those presenting to the board today to take into account the board members would have read the reports in advance of the meeting, and I'd like to ask those presenting to highlight the main points of the paper and draw attention to anything that might have changed since the paper was drafted. We are going to take a short break at around 11:20. I thought you might want to know that. Can I firstly, however, welcome colleagues to the board, perhaps those visiting for the first time. Before I do that, though, can I say I'm delighted that we have a member of the public observing the board in person today. Can I welcome Gemma Gash? Gemma actually lives in Cymtar Morgannwg, but is a new member of staff. And I think, Gemma, is it day 4, you said? Yes. Day 4 in the role. And I think it's fantastic that Gemma has asked to come to the board today as a member of the public, but obviously as a member of staff. And Gemma has put a question in, which Dom is going to respond to when we get to the performance dashboard. Can I also welcome Sue Wooler, a principal pharmacist who's here to share the listening and learning story relating to anticoagulation and the benefits of the self-testing scheme. Richard Hughes, Deputy Director of Nursing, who is attending on behalf of Greg Dix. Kerry Bear from Clais Cymru, who is attending the meeting on behalf of Daniel Price, the Regional Director. We have Sarah Uckley and Darren Griffiths from Audit Wales, who are attending part of the meeting virtually to present the Structured Assessment 2023 report at item 7.5, and Owen James, Head of Corporate Finance, and Mark Jones from Audit Wales, who are attending the meeting also virtually to take part in the discussion on item 7.6. I've been advised that Linda Thomas, one of our independent members, and Lisa Curtis-Jones, Associate Member, will be joining the team virtually, so very more welcome to colleagues who are joining us from slightly further afield. Can I just say, before we go into apologies for absence, Mark Jones from Audit Wales has asked if he could take item 7.6 on charitable funds annual report and accounts early on the agenda. So if you're in agreement, I suggest we take this immediately after the listening and learning story. Apologies for absence. We've received apologies this morning from Dilys Juvenat, one of our independent members, Helen Lentle, independent member, and Nicola Milligan, also an independent member, Anne Morris, associate member, Greg Dix, our Deputy Chief Executive and Executive Director of Nursing, and Simon Blackburn, our Director of Communications, Engagement and Fundraising. So we've noted those apologies. Can I just move to declarations of interest? I've not been notified of anything. Dom?
Sorry, Sally Bolton, so apologies to the Clinical Advisory Group Chair. She's meant to make it this morning.
That's fine. Okay, thank you very much. And in terms of the report that Sally will be presenting
I'm going to do
later on, you do it. Yeah, thanks, Dom. Declaration of interest. Anything that colleagues wish to add that I've not been notified of? No? Okay, splendid. Just to deal with the consent agenda, as usual, to ensure that we're focused on those matters that require our attention this morning. The consent agenda obviously is in the paper pack in front of you. Just on the basis that you've had the opportunity to read all the items on the consent agenda in advance of the meeting, are there any of those items that you'd like brought forward to the main agenda? This is an opportunity for all colleagues, both executive and independent members, to consider if there's any item that needs to be brought forward for further discussion. I know usually they're just there for noting or approval, but unless there is, I'll deal with those as usual when we get to them further on. Okay, item 3, our shared listening and learning story. Absolutely delighted Sue's with us this morning. to present the listening and learning story. Sue, I know you're going to say a few words before a video presentation is shared with members. Just to advise colleagues who are observing the meeting via the live stream, you won't be able to see the room whilst the presentation is being shared. And after the presentation, Sue, we might have some questions if that's okay. So hand over to you. Lovely to see you.
Lovely. Thank you very much. Thank you for letting me present this to you today. I've got a long history with CTM, so it's nice to actually see a board in operation. So I'm the principal pharmacist for anticoagulation, so I'm responsible for delivering the anticoagulation services across the health board, predominantly overall the Morgan, but also Chris Giles and Princess Wales as well. So without any further ado, the patient story will speak for itself, and then I've just got a little bit of a summary for you at the end, if that's okay. So thank you. Just playing patient story, that would be great. Some technology. Someone. And no teaspoons in here.
I'd like to give people a moment. There we go. Yeah. What's that goes?
Surgery, I've got to make an appointment. You can do it at home when it's convenient. And even though I'm not very sort of techie, I found it all quite straightforward, really. You know, after you've done it a couple of times, you really get used to it. And it's quite a simple procedure, really. Yes, it's a small machine, so it's easily portable, so you can take it anywhere. Yes, it's been great. It's not a complicated system at all. Because the machine does it for you, basically. Yeah, and of course we didn't realise the advantages when lockdown came, how marvellous it was as well, because obviously there was quite a few of us didn't need to go to the surgery. And then if Joe wanted us to check it at any time, we could just do that, put it through on the app. She sends the response back on the app, which is brilliant. And it's all instantaneous, really. It's so simple. I think it would take a lot of my confidence away. I know it sounds strange, but it almost feels you're in control to some extent to have a machine. And if I go on a holiday, I can check it and send it to Joe through the app. And we go away quite a bit because my husband's in a choir, so we tend to go away. And of course, you don't have to worry about cancelling an appointment or rearranging an appointment. It's all done remotely. So yeah, if it was taken away now, I think I would struggle, actually. Yes. Well, basically, when I first started having my warfarin checked, I was working, and obviously it meant I had to have an appointment to fit in with my work schedule. And of course, if the range was not good, you'd have to have it rechecked within a short time. So that meant another appointment. Whereas now, of course, if you need it rechecked, it can be done within seconds. So it saves quite a lot of time, actually, which I think is the big thing.
So the patient self-testing service has meant that we can work so much more flexibly. Patients like to test their INRs first thing in the morning, and then they transmit them to the surgery. So they're there by the time we get into the surgery, switch the computers on, the results are already waiting for us. The appointments are much quicker because the patients have already answered all their questions. We get back to them, we can transmit their dosing advice immediately, and the majority of the work's done before the real day-to-day stuff starts. It's meant that we've created a lot more capacity in the system. So we've got more appointments for patients who need to attend the surgery. We're able to do medication reviews, meds optimization, work that was previously done by GPs. So we're able to take that on now and provide that specialist service to those patients. We've also noticed that patients who self-test their INRs are more stable. So, for example, if they have a period of being unwell, they have antibiotics or anything like that, rather than having to take up an emergency appointment in the surgery, they simply test their INR, transmit it to us. We provide the necessary dosing adjustment and advice, and it helps maintain them in their therapeutic range for, for longer, which means that they're not at such risk of adverse events such as bleeding, worst case scenario, stroke, or a recurrence of a clot. So we find that evidence demonstrates that, but our experience also backs that up. And I just can't imagine having the service without them, really. One of the problems, obviously, is that we don't have a resource to replace these machines. So when they get to the end of their life, we aren't able to offer the patients an alternative one. Some patients are able to buy them themselves, but obviously the majority aren't, and so it means that they can't continue with what the service they've been having. So that's one of the biggest problems for us, is not having a replacement. And also we have new patients coming in all the time, and we're not able to offer it to people because the machines are already used. So yeah, what would it mean if we didn't have the service? Well, for a start, we'd have to send a lot of the work back to the GPs that we've managed to pick up. We'd have to create more appointments in the system, which ultimately would mean potentially longer waits and not being able to offer the service that the patients need when they need it, really. So.
There is a short slide just to round that up. So if you're able to just put that on, that would be great. Okay, so the next slide, please. So why are we here today? So I think most of you are probably aware that warfarin, you've heard of warfarin, it's a high-risk medication which needs careful monitoring, and historically it was done in face-to-face appointments, GP surgeries, hospital clinics. The scheme that's just been detailed there describes how patients with long-term health conditions have been able to take control and really have an impact on their own self-care, really. We currently have approximately 150 patients across CTM who are testing their own INRs. You've heard from Jacqueline today the benefits it's given to her personally. You've heard from the pharmacist, me, about the impact that the scheme has had on how healthcare professionals can support patients on warfarin, how the scheme's enabled us to see more patients, but also help the GPs with other vital medication-related work. What hopefully came across as well was the additional clinical benefits of optimising warfarin medication. Importantly, decreased hospital admissions for strokes and major bleeding. So we need an investment basically to continue and extend the scheme. And the investment needs to come from somewhere, but obviously the benefits will be seen in lots of different areas: primary care, unscheduled care, planned care even. So I feel it needs a sort of cross care group investment strategy. I have worked with primary care, pathology, haematology, and put together a detailed business case on the benefits of the scheme and also the relatively small resource that we're requesting to make it happen. So I guess what I'm hoping is that the short presentation and the patient's experience will be at the forefront of the execs' minds while they're having a look at that business case. So really it was just to highlight the importance of the scheme and to give you the opportunity to ask any questions if you have any. So thank you for allowing us the opportunity to share the patient story. And we had a number of patients queuing up to do that, actually. There was a lot that really wanted to demonstrate to the guys at the top, as they described it, the benefits of the system for them. So happy to take any questions.
Thank you very much. Okay, any questions from the comments? Sorry, Dom.
Firstly, thank you, Sue, personally, because I know how much time and dedication you put into this, and I know we're that much thoughtful because of what you do. And whenever there's an issue on it, people just say, "I was going to ask Sue." If you might credit you, I suppose I can completely get it, and I think this is a wonderful service and exactly where we need to go when you think of how many patients that we have on it. And how are we? I suppose it's a question I know the answer to, so it's a sort of there. How are we getting better at working it the same across the whole of CTM? And I know we've got different approaches in POW. I know we've got a consultant who leads on BTE. We've got a different approach in PCH. And so I suppose part we wanted to look at is where we need to be going is how do we offer that service across the board so that everyone does it? And even if I know it doesn't need to be doctor-led, it needs to be pharmacist-led, it needs to be therapies-led, because that's where the interaction is. So that's, I think, fully behind what you're saying and the direction I'm there, but I just wanted your thoughts on that.
Yeah, I mean, you're spot on there, and I think that's been a passion of mine for forever, really. And we're lucky now that in the position that we've had a reorganisation within pharmacy, and I've got a health board live remit now, which has given us a lot more opportunities to try and spread. We've been working very closely with the nurse-led service in PCH for a long time now, and I think our track record demonstrates that the benefits of of having that sort of clinical lead in that role. And I think there's opportunities now for us to work more across that. There's a slight problem with the Princess of Wales because of the SLAs and historical connection with Swansea Bay, which will ultimately change. But I think we're in a very good position to move things forward. And I think examples like this service, because this has COVID really helped us with this. We'd done it in a small pilot in RGH, and we were able to extend it to Prince Charles, and they saw the benefits. And we are by default helping out Princess of Wales now and again with areas. So we're getting there, but it's a bit of a journey. Yeah.
Thank you. Ian.
Yeah, I think this looks great. I mean, this is exactly the sort of way we should be going. I think it ticks a lot of boxes as far as I'm concerned. I mean, in terms of population health, patient self-management, take the pressure off the health service, I think is thing that it does. And also it showed efficiencies in terms of taking all that load off from primary care and so on, which would have otherwise been tying up a lot of time for GPs and so on. And patient safety as well. So it ticked a lot of boxes for me. I thought it was great how it showcased digital technology and how we could do all those things. So I'm chair of the Digital and Data Committee, so you expect me to say that. But I mean, it does show that. But look, one question on the top of that, however, and this might show my complete ignorance, but as far as I understand it, there are alternatives to warfarin. So why don't we just prescribe everybody the alternatives, or am I naive, instead of using warfarin?
And we are, and that's been a big part of my life for the last few years, actually. And we absolutely are. But there are some conditions that can't have the new agents, particularly the high risk patients such as valve replacement patients, and they're the ones that are high risk and are difficult to manage, and certainly will never be able to have the newer agents. There are a small cohort of patients who, for whatever reason, drug interactions, age, renal function, etc., also can't have the new agents. So warfarin will always be part of our lives. But in fact, that's a challenge in itself, because the less people that are on it, the less specialists, the less experienced people, clinicians have with it. So again, the role from patient safety point of view of having pockets of people who can manage that, and getting engagement with a small number of patients that are still left on it to help them manage it safely as well. So it is a win-win.
Right, thanks.
Paul. Thanks. And it was, as Ian said, really good to see. I guess my question was, you mentioned that in your overview and about savings in primary care. So when we're talking about efficiency, I guess my question is, how are primary care contributing towards this? Because with the best will in the world, if we're saving efficiency in primary care, that's appointments saved in primary care, and therefore I would suggest that it isn't just us think about this. It's maybe it's good to hear you talking to the other care groups as well. Could I be asking GPs, if this is part of your attempt to diversify your workforce, move things away from the GPs to pre-GP appointment times, that also brings efficiency for them. So have they offered, or have the conversations been had with them about potentially contributing towards? Yes, it's
a tripartite arrangement, really. So medicines management with the clinical input, pathology with the point of care expertise and digital expertise, and then primary care from the fact that the majority of the patients are managed in primary care. That said, a lot of these patients that are valve replacement patients are complex clinically, so we tend to at least support that service in secondary care, and they tend to flow between us and primary care. So it's it's definitely a collaborative approach. And we worked very closely with primary care previously. This all grew out of a project which happened in primary care, which was a research project looking at the benefits of self-testing in the first place. That's where it's originated. So they're very much involved.
Okay. Yes, sir. Ben.
Thank you, Sue. Very interesting. As with all new projects that are presented to us, the question I usually pose is this our project? Is this an initiative that we developed, or is it something we've adopted and adapted from somewhere else? If the second is true, what have we learned from their experience? And are we recording our experiences they can tell us? I know there's two issues there.
There are pockets of big self-testing going on in areas. You know, many years ago, certain places in England went in a much better way. So we've sort of learned from other places, I guess. We've been enabled with technology, with the digital connection now with the surgeries to be able to expand and do it that way. So we have learned from other areas, and we are capturing our evidence and presenting it around. So, for example, I presented a paper recently at the National Thrombosis Conference about the benefits of self-testing. We actually won an award recently for our contribution to patient experience in the VTE pathway, and that partly involved some of the self-testing things. So, yeah, I think it's a bit of both, really. We've learned from other areas, and we're experimenting and trying new things and publicising it here as well.
So it also where what didn't work, so we don't replicate those mistakes ourselves.
Yes, definitely. And I think technology's been a big help for us there, because things have moved on there, and that's been a big help for us too. So yeah.
Thank you, Sue. Thank you, Chair.
Karen.
I've got a very basic question. How much do the machines cost if the patients have to then buy another one potentially?
299 ex VAT.
And is there a kind of commercial angle to this? Do we have an agreement with the company? Is it in their interest to re-provide these, given that they must make a lot of money out of?
Yeah, so that's where our links with point of care come in very handy, invaluably really. So we originally got the machines free of charge as part of a research project, at the first batch of machines, and then when COVID happened, our links with industry really helped us, because we sort of jumped in there quickly and actually managed to acquire, it sounds a bit selfish really, but we did manage to acquire a rather large number of machines ahead of some of the other health boards, because we were already engaged with the companies that way. And we're looking at actually incorporating them into a managed contract, so that we will get some benefits from a cost and renewable sort of service point of view that way. So there's a few angles to it, but yes, if the patients were able to buy the machines themselves, there's a very good network of support from the companies about that. There's lots of apps and internet learning for patients, which we have tapped into when we've been teaching patients. So yeah,
it's good to know the commercial side of it is part of that, because often I think we don't necessarily explore that. But
oh yeah, no, we've worked very hard, and that again has been due to collaborative work, predominantly with pathology and point of care.
Thank you.
Okay. Any further questions from colleagues? No, that's good. Thank you for joining us this morning. Susan, just stay for the rest of the meeting. I suggested that being able to observe the board might be helpful. So you're very welcome to stay, but thank you very much indeed for the presentation and for the story. Thank you very much indeed. Okay, we'll move on to item 4, and starting with my chair's report at 4.1.
Get the Mark in, so.
Oh, sorry, apologies, Mark. Yep. Mark, you were there?
Yes. Yeah.
Sorry, Mark. I was rapidly running into the chair's report, and I was reminded that we were going to deal with item 7.6 on the chapel accounts. So good to see you this morning. And Sally is going to introduce this. And I think any comments then from colleagues from Audit Wales would be appreciated.
Yes. So I'll do a brief introduction. As you'll recall, we are the trustees of the charitable fund, and therefore that is why this annual report and accounts are in front of us. There is a little bit of an issue in that the full set hasn't been correctly uploaded to admin control, but I think Emma and Callie are doing that now. So we've got the full set of accounts in front of us. But I think the main issues to bring before you here are in terms of Mark will talk to us about the independence examination by Audit Wales, and I'll refer to that. And just in terms of our position, there's one what's called non-trivial uncorrected misstatement highlighted in the Audit Wales report. That's the valuation of the investments held with the CCLA. The reports provided throughout the year at mid-price, and we've used that in the accounts. The statement of recommended practice suggests bid price to be used. The difference in value between the two is £3,622. Triviality level for our charitable accounts is very low, which is why we are reporting that as an uncorrected misstatement. But to put it in context, the overall value of our investments was 2.76 million. So it is a fairly minor difference, but important to highlight. So I'll hand over to Mark to take us through his audit report.
Thanks, Sally.
Thanks, Sally. Thanks, Chair. I'll keep it brief for you and largely take it as read. But this report discharges our responsibility to report to you before you consider whether to approve the audited annual report and accounts. The most important message is that we intend to issue an unqualified, that's a positive opinion on the accounts, so they're materially true and fair, and that's the main element of the audit opinion. And the proposed audit certificate is at Appendix 2 of the audit report, and it's in the accounts themselves, of course. The Auditor General is scheduled to certify on Monday, so that will be ahead of the Charity Commission's deadline, and they will no doubt be sent to the Charity Commission on that day. The audit does say, this type of report always says that the audit is substantially completed. It says that in paragraph 4. The reason it says it's substantially completed is because the audit remains open and ongoing until the point of certification on Monday, because albeit unlikely, there could be a significant issue that comes to our attention that could be relevant to the 22-23 year of accounts. So the audit remains open until certified. And as part of that process, on Monday, Sally is required to confirm that she would still sign the same set of accounts on Monday, that she's subject to your approval, will be signing today with Trustee Chair and Chief Exec as well. There's the uncorrected misstatement that Sally's covered. The corrected misstatements are at Appendix 3. There's very little in Appendix 3, which is a reflection of a very good job, an excellent job by the finance team and certain other colleagues as well. So that reflects strongly on the quality of what was presented for audit. There are 4 recommendations in Appendix 4. Management have accepted all 4 of them and provide commentary on that. And finally, there's the letter of representation at Appendix 1, and that's for the Chief Executive and the Chair, yourself, to sign those assurances to the Auditor General. So that's another key document. But other than thanking all the officers who helped us through the audit process, I'm happy to take any questions at that point. I can't hear you, sorry. Hello?
There we are, Mark. Sorry, can you hear us now?
Yes. Yes. Sorry. You heard what I was saying about the report. Did you caught that?
Yeah. Mark. We heard all that. I was just asking the board if there were any questions to either you or to Sally before asking the board to approve. But I don't think there are any questions or comments from the board. So on that basis, is the board content to approve the item in front of them this morning? Yes. Okay. Thank you very much indeed. There we are, Mark. Quite swift this morning, which hopefully is helpful to you. So I know you've got some other business to attend to this morning as well. So thank you for joining us.
Yes.
Okay. Thank you very much. Thanks.
Could I ask a question which isn't related to the accounts per se? This is about the policy question on the charitable accounts.
Yeah.
So it's about the unrestricted funds for carrying forward 2.6 million, and we've just heard this sort of presentation now about perhaps some people not being able to afford self-testing kits. Would that be something that could be considered in future from the charitable fund or not? Is that not
So
area?
the objectives of the fund are around providing things that are over and above core services.
Yeah.
So in looking at any proposal, and we haven't seen one around that, we have to consider how it tests against the objectives of the fund. So that would be the process for looking at that. You might argue that this is core, but that was something we would have to debate and consider.
Okay, thank you. That's all I wanted to know.
So we do have a question from Linda as well. Thank you, Linda.
Yeah, it was just, hiya, good morning. It was just really to respond to the question that was just asked, which I think was by Kath. Just to say, Kath, we as the Charitable Funds Committee are going to be looking at everything this year, including the use of restricted funds. So with my background, I know that there are ways and means around restricted funds and things that we can be doing. So the objective that we will have this year, I think I'm right in saying, Sally, is we're going to spend and raise, because we're going to have a whole new revamped fundraising focus.
I like the idea of raise, spend, but let's work in that way.
So yeah.
Linda, I know we're close to an A&E department, but I don't want to cause a medical emergency with our finance director. However, look, it's good to know the committee are looking at this with some ambition. Let's put it that way.
But Linda is right. We should not hold the funds.
No, we should not.
We should utilise them for the purpose on which they're granted.
Right. Yeah.
But we just need to refresh our processes to make sure that we're really demonstrating that as we work through it.
Absolutely right. Yeah. Thank you. Thank you, Linda. Are there any other points of clarification or any matters of interest that people want to raise? I know we've approved the item. Mark said we have approved the item, so thank you for joining us this morning. Good to see you as always.
Thank you.
Thanks to everyone. Thank you. Okay, we'll move on to item 4 and the chair's report. The report is for noting. There are just a couple of things just to flag up at the end of the report in respect of the use of the common seal and then chair's urgent action that was taken in respect of the COVID-19 inquiry model 6 application for core participant status, which was approved by colleagues via email. So just before I ask you to confirm your approval and endorsement of the use of the common seal and the chair's urgent action, just to flag up and to reiterate my thanks to the executive team and all of our staff who in the past few weeks have been dealing with some significant challenges in the delivery of our services, not least the use of our business continuity measures during a huge spike in demand for urgent care across our hospitals. I really appreciate the speed at which our teams have responded to that particular challenge, particularly where we have had very large numbers of people who have been medically fit to be discharged from hospital, but have been unable to be discharged because of challenges and capacity issues elsewhere in the social care system. Following that, of course, we did have the junior doctors' strike. And again, our thanks to the board, to the exec team and all of our staff who have worked incredibly hard to respond to that challenge and to mitigate the impact of the strike on our patients. I have to say, I think the response was remarkable, where we as an organisation did everything possible to keep as much of our service operating and running and to reduce the likely impact on patients. I know that there's some listening and learning around that. I know we don't yet fully understand some of the implications, particularly around cost, and I know Sally and the team are working through what that has been to the health board, but clearly impact on patients and families and staff. I think it's worth us reflecting on that, particularly as we plan for potential further industrial action in the coming months. But I'm acutely aware of those challenges, how hard people have worked, and I think it's right that we as a board publicly acknowledge our thanks to all of our colleagues here and outside of this room who have worked exceptionally hard to respond to all of that. So my thanks to you as chair. There's nothing else I was going to say on my report. Are there any questions on my report before I ask you to endorse and approve the use of the common seal and the chair's urgent action? No? Okay. Can I ask you therefore to endorse the use of the common seal on that one contractual matter and just to reconfirm your approval for the use of chair's action in respect to the COVID-19 inquiry? Thank you very much indeed. Okay. Just moving on to the action log before moving to the Chief Exec's report. What I'd like to do with the action log, there are those matters that are still in progress, and there are those matters further on in the document that have been completed. If we can just look at those matters that are in progress, some of those are going to be dealt with in board meetings and board development sessions that take place slightly later in the year. Is there anything that colleagues wish to raise at this point in respect to the action log?
No.
Okay, if I could just ask you to note that document. And I said there were those things that will appear on our agenda over the next couple of months, just to assure you that just because things are in progress, they haven't been lost. Okay, item 4.2, the Chief Exec's report. Paul.
Thanks, John. So just a couple of things from my report to update on escalation, and I briefed some of the independent members yesterday on this topic. Since the report was written, we've obviously had confirmation this week from Welsh Government that our escalation status is remaining unchanged in all domains. There will be further review of that position in the coming months prior to a formal tripartite meeting, but the plan is that the message we've had and the correspondence I had this week is that that's what the Minister has determined. So as a brief colleague yesterday, we are waiting further updates in the coming couple of months about whether there is a plan to further de-escalate the Health Board, particularly with relation to quality governance and maternity. So that is ongoing at the moment, that discussion. We also had, prior to Christmas, the allocations for next year, and a lot of work being done at the moment by colleagues in finance and planning to look at what that means in terms of our financial position for this year. For this coming financial year, there is a clear message from Welsh Government that the expectation is that health boards will produce balanced plans for next year, or if they can't produce a balanced plan, be able to describe how they're going to move to a balanced plan imminently. And we have to, if we're not able to deliver a financial balanced plan, I need to write an accountable officer letter by the 19th of February to Welsh Government. So we'll obviously further updates on that as the planning and financial picture becomes clear in the coming weeks. I think we've got briefing sessions planned for independent members and others in February, so we can bring you up to speed with what that's looking like for us. Also, just wanted to highlight that the final few posts have been appointed to now in the operating model, which, you know, there's been a big pre-programme of work over the past few months for the phase 2 of the operating model, which is really positive, and I think it's great to see that those posts are now being appointed to, and that we will be from the beginning of April fully established with those new posts. And what's great is we've got a mix of people from within the organisation, within Wales and beyond, who are being successful in those roles. So I think a really great opportunity to now move forward in our new care group operating model. I think Lauren also just wants to update on one role, particularly in the therapies and sciences area, which is quite innovative and different. So Lauren, do you want to just
Yeah, thanks, Paul. Just to flag that within the operating model changes, we managed to use resource differently to create a clinical director for healthcare science. That's the first post in Wales. And I think it's a really strong recognition of the feedback that we got from our frontline clinicians in terms of the visibility and profile and leadership for the sciences, and also our recognition as an organisation in terms of the value and our direction of travel in terms of diagnostics. So really exciting.
Yeah, no, that's really good, Lauren. Thank you. And just finally, many of you will know that last week we had our first in a while, long service recognition award, where we celebrated the colleagues who've worked for over 40 years in our organisation, and John and I were there, and it was a really fantastic event. And thank you to Simon and Sharon and all the other colleagues in comms and from the people team who worked so hard to put that event on. It was a really great celebration of many years. I think we counted, what was it, over 4,000
years
of service across the people who were in the room, which I think just shows you the value and contribution many of our colleagues have made over many years. And it was a great opportunity to celebrate that, and we were fortunate that the Lord Lieutenant came along to host or provide input into that session, and great to see the sort of discussions that were going on, and colleagues who hadn't seen each other for a long time, who trained together many years ago, all sharing their experiences and
stories of their time in CTM. So really great, and that will be the first of a number of events that we'll be looking to bring in over the next few months for recognition at different time periods. I think the next one is a 30-year. Yeah, really positive to see that, and long overdue, which I know has been talked about in this board for a period of time.
Thanks, Paul. Matt?
Just coming back on this, I mean, the feedback has been overwhelming. It's excellent. There's just one little thing to make sure when we do those next ones, there will be some people who did 30, 40 years, even 50 years, who couldn't get for some reason to that event.
Yeah.
Not for them to sort of
No,
be missing.
they haven't been mistaken.
No, we've either offered. I think we are either going to take things out to people if they couldn't make it, or they'll be invited to come to another one. The challenge with this event is making sure our records are up to date. So we've had a number of people who've come out of the woodwork saying, "Well, I've worked over 40 years and I wasn't invited." And there's all sorts of machinations about how it's recorded on ESR. People who left one organisation, worked in another organisation, come back again. All of that, but in some ways, until you start, you don't know that. So we're flushing out all those issues, and we're making sure that we're catching up the people who missed out this one will be invited to a follow.
And I just see the Lord Lieutenant, brilliant day there. You thoroughly enjoyed it.
Yeah.
So it was a lovely event. I must say that you're realising that all those people in the room had been involved in the National Health Service for more than half of the lifespan of the National Health Service, and in some cases, for those who have 50 years, 2/3 of the lifespan. So it is just remarkable. It's probably the only area of work in the world that people would probably want to be involved working in it for that length of time. I think it is. Paul was right. It was just fantastic listening to the conversations that people reconnecting with colleagues they haven't seen for some time. And if you put that in the context of the other work that Simon and the team have done, particularly around the Seren Awards, the staff awards, those nominations, we're getting hundreds of nominations from staff members nominating their colleagues for awards. I think is just fantastic, and the more that we can do, that public recognition is so important. It really is. So thank you, Paul. Any questions to Paul on his report? No. Okay. Thank you very much. We'll note the report. Moving to item 5, delivering our plan. We're going to turn to the integrated performance report first, with quality, people and operational performance. And I'll come to Linda first. Sorry, Linda, just want to see at the end of the table. Thank you.
Thank you, guys. So I'll just bring your attention to the summary at the front on what is page 28 of 372. So just note that we're using this as our sort of high level sort of indicator of where things are, the most important metrics of the metrics we already measure. And you'll see that actually it's a pretty positive picture this month. And I think those indicators that have gone in the wrong direction with a red arrow tend to be the more volatile ones. So they'll be up and down a bit anyway. So I think that paints probably one of the more positive pictures we've had for a while on performance. But that sort of brings me to the fact that I know that this is a sort of interim form of this report, trying to just provide that bit of a high level. We are still working on a report which does bring to your attention the most important things in terms of outcomes and more time series type of indicators, so that it's easier for you to pick the wood from the trees, if you like, and we'll work through what we do with all of the whole of the range of indicators as we've discussed before. So we've got as far as I think we can with our sort of current system, and we are looking at a different system to identify more sort of outcome based types of approaches to help you look at strategic performance, not just operational detail. However, talking of which, we're going to hand over to Gethin for the operational delivery.
Thank you. I will just draw out a couple of key headlines for consideration by board, but happy to take questions on the rest of the report on anything that people wish to raise. So if I first of all focus on mental health, board members will be aware of some of the challenges that we've had, particularly in our CAM service, and I think the report really sets out clearly the sustained improvement that we've achieved the hard work of the service in addressing our services, and really seeing that, and certainly the data for January also demonstrates that we continue to sustain that in that way, which is really, really positive. At the previous board, I alerted you to the drop in performance in adult mental health, and I'm pleased to show that in the report that's recovered, and again is recovering further this month. So our key and the final bit around psychological therapies. So the psychological therapy performance for December was at 65%, which is the highest it's been for some significant time, and again is testament to the hard work of a very small team, and I guess partly in recognition of the gaps that we carry within our psychological therapy service. So you know, the team are working exceptionally hard to ensure as timely care as possible for those patients. With regard to urgent care, December, of course, is always a tricky month, as we both meet the demands of winter, but also try and create capacity in our acute hospitals for the pressures that we will know we will incur in sort of the festive period. I'm pleased to say this year that we went into the festive period in a much stronger position than we had in the previous year, and managed to de-escalate around 50 beds at Prince Charles, 50 beds at the Royal Glamorgan, and 30 beds at the Princess of Wales, in preparation for the pressures that we know that we will incur post Christmas. And whilst the performance is nowhere near the level that we would want for our patients, and you know, clearly we're striving for that, I think it is important to recognise that our performance in terms of being seen and treated and discharged was 3% up on 2022, with an increased level of attendances. We had 317 patients fewer in December this year, wait over 12 hours for onward transfer to a bed, and when you consider the pressures that we have on our inpatient capacity is really positive. And of course we saw an increase of 21% on the number of conveyances to our front door in December, and I'm pleased to say despite that increase, we still saw an 8% increase in 15-minute handovers in December, and a 12% increase in the volume of ambulances that we handed over within 1 hour. So we continue to sustain our position as sort of the second best performer in terms of ambulance handovers. Again, nowhere near the level that we want. We want to be hitting, you know, 60-70% within 15 minutes. But we continue to reduce the volume of patients that are waiting excessively long times on our forecourt, but more importantly, that it supports the ambulance service to response patients in the community. In terms of planned care, again, December is always a lighter month for activity because of the number of bank holidays and patients not wishing to have operations in the run-up to Christmas, unless they're desperately trying to get out of cooking the turkey. So we did see a slight reduced level, but that's a position that's mirrored across Wales, and we continue to be the second best performer in terms of our longest wait. So our volume of patients waiting over 104 weeks, again, we continue to bring that down. There are a number of initiatives we've got going on with GIRFT, specifically looking at our ENT pathways, because we know we've got cohorts of patients there that probably can be managed in a different way. So we're working very closely with GIRFT and national best practice there. And as part of the expansion of our orthopaedic capacity, we've brought back online as a general operating theatre the old obstetric theatre at the Royal Glamorgan. That will allow us to remove some capacity around, which means we'll open up a second dedicated orthopaedic theatre at Royal Glamorgan for primary arthroplasty, and will also allow us to bring all our breast operating onto the Royal Glamorgan site. So as part, so Royal Glamorgan really becoming a focus for our breast service as well. So that's a really exciting development for April. I am also just board members will remember the business case and the detail we went into for the purchase of a surgical robot. I'm pleased to say that the robot did its first patient yesterday, or driven by Paul.
That's reassuring.
So we had our first surgical patient done with the robot. Patient's recovering well this morning, and we have the second patient being operated on using the robot today. So a huge testament to the work of the surgical team and the clinical team at Wimbledon Morgan to get that running. So and again, so great that we're able to offer that level of technological advance to our population here in CTM. I think that's such an important step forward. Bearing in mind we have the highest level of colorectal cancer in Wales, so it is important we can offer that cutting edge technology. In terms of cancer, again, you can see the detail on page 18. I think it is just worth remembering in December 22, our cancer performance was at 40%. We've increased that to 55.6. Again, nowhere near the levels that we want it to be operating at. But again, we're seeing really strong improvement. Linked to that, for example, the focus on endoscopy. So in October, we had a 25-week wait for bowel screening patients to have an endoscopy. That's down to 11 weeks in December and will be at 2 weeks by the end of March. So again, really focused efforts by the team on that, and again, very big focus on our urological services where we have the biggest challenge with delivering against them. And then finally, just picking up on diagnostics, I think it was worth that continued reduction in endoscopy waiting times and the focus on non-obstetric ultrasound. Again, we're seeing a real focus from the teams in reducing that, and we've gone from over 10,000 patients waiting over 8 weeks to now 4,000, and on track to bring that down to 7,000 by the end of this financial year. So again, really trying to improve the access to our patients for key diagnostics. I wasn't going to say any more than that, Chair, but I'm happy to pick up questions at the end.
Thank you, Gethin. On this order, you'll wait until the end, so we've gone through.
Okay, I'll wait to the end.
Yeah, I thought that was the executive first, and we can, okay. Thanks, Gethin.
Over to me next, that's right. So there's a lot to talk about here, but there's just 2 areas I want to pull into. One is on the report of the mortality rates, and the second one is Gemma's question, which I'll come on to just after this. On mortality, I couldn't come to the meeting without talking to you about mortality data. So as you can see from page, for those of you looking at page 31 of document 5.1, there has been a consistent downward trend on our crude and our adjusted mortality. There are a number of reasons for that. One of them is because we're actually starting to align a bit more with the rest of Wales, in that we've had more admissions to our emergency department. Therefore, our number of case denominators has gone up. Therefore, the proportion of deaths has changed slightly. So I think I remember the last meeting I mentioned this is how the rest of Wales records it, that we felt very strongly that the spirit of it is to show exactly what your deaths are, not to try and change the figures on there. What I wanted to just make you aware is that there's a national meeting on mortality next month, and I'm leading on work stream on data for Wales. And part of what I'm putting in there is we will be seeking to agree across Wales exactly how we're all going to report it, so we will do it exactly the same. We've made significant progress on the way that we're going to start tackling it. What you can see here is the Office of National Statistics data. So there is a lag in that data where you're looking at October 23. That's the way that all of Wales do their reports. We've done it the same way in London there. But what we're going to have is far more of a day-to-day response. When we have our package in place, we'll be able to drill in much better into that data. And I'll be able to bring to you the report of what it was up to last week. So that's what we're aiming at. Okay. So there is progress there. Part of it is to do with the permissions we've got, but part of it is because we're going in that direction as well. Happy to pick up questions on that, obviously, as well. So the next thing was Gemma put a question in to us. Would you like to read out the question? Is that the easiest thing to do? Jonathan, just to record it, or is it already recorded elsewhere?
It hasn't been recorded, but if you've got it in front of you.
Got it in front of me, so I can read it. So if you could read it out. Jump in if I say this wrong at all. It's a really, really good question, and it's really pertinent to exactly what's going on with the health board. So I'm actually really grateful to you because it gives me a chance to answer it. So it's what is the health board stance on frailty and closing the gap between physical and mental health, considering we have an ever-extending older population with people living longer with multiple comorbidities and further cognitive impairment and dementia. How is the health board going to prioritise frailty and care of the elderly, ensuring a holistic care pathway where all individuals' needs are met physically, psychologically, socially and holistically? So that's the question. There's a long answer, so I will edit it down, but I'll catch up with you maybe at the end of this to give you a bit more detail if that would help. So this absolutely is the goal of our care of the elderly teams across the whole of the health board. What we're trying to do is deliver it in a very different way. The way we've been doing it up to now clearly isn't managing to get that whole holistic approach of everything in. So we need to start thinking differently about how we actually go about doing it. And there are a number of ways we're doing that. We've set up, so Princess of Wales, we've already talked about a previous meeting here before, and we talked about, of course, in safety, about how they've done now a model of the front of doors. How do they see patients immediately, bypassing the emergency department and get them back home to prevent them from missing them in the first place? Because we know the best place for them is at home to manage all of that. Prince Charles are going live with that next week. They're going to start process. They have a slightly smaller team, but still they're going to lead and drive on there. And Royal Commonwealth have plans to do the same thing as well. That's a kind of fledgling service, and we're looking to really develop that up. And how can we actually start almost having a, in 10 years' time, could we possibly have an emergency department for elderly people that we can actually see into and have all the right team in there? So that's part of it. That's the acute side. And there's also a lot more to do with our overall strategy in the organisation of moving more of our care into the community, and that is really here, particularly dementia patients as well. We don't want to bring them into an unusual environment, and we do all the best we can to adjust to that, but they need to be managed in their own communities, in their own homes. And so there's a huge amount of work going on there. How do we use our community services better to link in? How do we use the third sector even more? There are lots of discussions going on at the moment about how we're going and doing that. So there's a huge piece of work there that the community and primary care team are looking at. But the one shining beacon, it's a shame Dilys isn't here, otherwise I'd ask her to actually describe this. Dilys and I did an exec IN ward under Ward 3 in Prince Charles. It's just one example. There's exactly the same in Royal and Wilton, and there's another lot of ward coming on. The PHM is the same. And it's a care of the elderly ward, but you wouldn't know it when you walked in. Yes, you've got all the acute beds, but they, from their own initiative, they developed a therapies room. They bring all the patients every day their activities, particularly around seasonal time. They did a big Halloween thing, they did big Christmas things. All of the patients are brought to that room in sequence. Even those who can't come into the room, they go to do something by the bedside with them. And that's activities, discussions, working. The room is incredible, and this is all done by staff and their families, volunteering or being volunteered to come in on the weekends to put up things on the wall and to develop things. It's absolutely amazing. They've also put in a bench halfway down the ward with a bus stop sign, because again, it's where people sit and wait for the bus and they sit and chat, and it's a really good focal point. So some of the ideas they've got are absolutely amazing. And if you'd like, Gemma, I would happily organise and put you in touch with them so you can go and see what they're doing, because there's a huge amount that they could get from you, you've got in the mental health side, but also you could take that across. And then finally, the only other point I want to point out is that we have dementia champions in the organisation. We really are promoting that and pushing that forward, as Richard will be able to explain. We also have a very good dementia training module on our ESR, which actually is mandatory training for everyone working in that area, and our compliance level is pretty good. But in short, we are doing stuff. It may not look brilliant at the moment, and I'm prepared to admit that we're not there yet, but we are definitely going on the right way to try and address all of that. But happy to pick up for you, because I'm sure you've got some great ideas that we could feed in and work across the different sides. Thank you.
Do you mind if I just quickly add to that, because it is a relevant point, because you mentioned that we had a presentation on quality and safety from one of the consultants, which was fantastic, about just looking at care of the elderly in a different way. And what really struck me about that was one of the decisions is, what do we not do? At what point do you say you don't put people through scans, and you need to weigh up what is best for that individual, not necessarily just looking at a medical model of what scans, etc. can we do. But the Quality and Safety Committee this week had a presentation from Adam Cook-Young, who's a clinical practitioner in care of the elderly. And it was an absolutely really powerful presentation describing the patient story of a care of the elderly patient who was admitted and was subject to significant delayed discharge, when actually his needs were social needs. And I think the whole committee felt that it really brought to life for us, when we look at statistics and we look at what happens, it's very easy to not understand what is happening to that individual. So I think Gemma's question is very pertinent, and we're all looking at this, but actually it is about working with voluntary social care. We are looking at all those things, but that case study really illustrated the impact on the patient of being in the wrong place for an extended length of time. And I always think it's something we should all hear, because it was so powerful for the committee to understand that is what we're looking at. It's not the right place for the patient, but we need to work with social care, and that we know there's a complex system of needs around that. But I just wanted to highlight that because it is something that's very stark that's come. Thank you.
Thank you, Karen. And that's it from me. So I'm going to hand over to Hamilton. I'm sorry, Chair. Don't worry, you can back there.
Before we go to Ron and Hal, which are doing it.
So there's a question from Garen Hughes, who's actually an independent member, who's dialed in by the Hopkins, sorry, Hughes, yeah, I think it looked like it. And he was asking if you could ask about childhood vaccination. There's been some discussion nationally about vaccination trends being down. So what are we doing here within the health board to ensure as many children are vaccinated? So then that's me.
They are down nationally. I was just looking at the figures, and that's specifically around MMR. Obviously, it's okay. Sorry, let me just jump in. We're doing mop-up campaigns really when we're identifying areas where we have particularly low uptake within schools, and we're sending in vaccination teams to mop that up. Okay. But we have seen it across the board, and that's been winter vax as well. We're seeing increased vaccine hesitancy, and we're doing in the background. We're doing a lot of behavioural science work to understand why people are hesitant to be vaccinated and have their children vaccinated, etc. But it is a national issue that we're in.
Thank you. I'll take that up to them.
Thank you, Philip. That's much appreciated. Thank you. Okay, unless any question this one to Dominic, and I think there were some questions towards the end. I'm going to Lauren first, and then to Hannah. Thank you.
Thank you. So a few points that I wanted to pull out. So I'll start with stroke. Obviously, that's a priority for us as a board, and that's why it features in the front page of the integrated performance dashboard. So again, improved thrombolysis rates. As I said last time, these are small numbers, so there is considerable fluctuation. Also, just to clarify, so it talks about 33% of eligible patients thrombolysed. That's thrombolised within 45 minutes. So more patients were thrombolised, just not within 45 minutes. So we'll clarify that in the next version. In terms of some of the other metrics, so we've talked before that some of these metrics are stubborn, largely static. And we've talked about the challenges of what we can do within our current resource and what requires additional resource. But some positives I wanted to share. So the early supported discharge team expanded to the agenda area has now launched. So we should start seeing an impact in the January-February data. So you'll see that there's an additional metric in here now. So you've got that baseline, so we should be able to track the impact of that service. We've talked previously about the prep work that was underway for the Brainomics artificial intelligence, so the reading of the scans. So that went live in December. So we're anticipating an impact in terms of the speed of diagnosis of a stroke and the knock-on effect that that has in terms of the time-sensitive treatments. And then Bristol has also recently extended its hours again for thrombectomy. So they're working towards trying to get a 24/7 service, but they're not there yet. But we've now extended to 6 a.m. till midnight. So there's a further extension, so that gives us a bit more of a window in terms of getting people over there for thrombectomy. So a detailed report on stroke comes to Quality and Safety Committee and the associated scrutiny there. So I just wanted to give you some assurance that the detail is being looked at. And then moving on to our AHPs, Gethin mentioned the psychological therapies in our mental health services. So that's the best position that they've been in 12 months. Work is ongoing, but there's a really great project happening with Improvement Cymru. So trying to set up a peer-led system for people accessing primary care mental health teams. So there's some peer support there while people are waiting for our services. And then on page 19, you'll see that there's an improvement in speech and language therapy performance. So the weights there are mostly in paediatrics. And you may well have seen some of the recent info in the news in terms of the impact that COVID had on the development of children's speech, language, social communication development, and the knock-on effect that that's had in services. So it's positive. The demand is high, but we're seeing an improvement in terms of those lists. You see the majority of the weights continue to relate to dietetics. So again, we discussed that in Policy and Safety Committee. It's on our risk register. It's part of the Creating Health portfolio because we know it's a significant challenge for our population in the CTM footprint. And we also know that there's a need for the paediatric service. So our WISE service is also having a focus in terms of weight management. So they're looking at their offer. We're signed up to a whole systems approach in terms of managing obesity. So tapping into opportunities to work with partners where we can. So they're my headlines. So I'll hand over to Hal.
Yes, thank you, Lauren. Thank you. Oh, thank you. So just got a couple of things I just wanted to pick up. And it's probably best to look at page 24 of 34 in the pack. There are two workforce pages, but the page 24 gives a better scale in terms of the graphs and the narrative as well. Just three areas I wanted to focus on. So sickness, we have two more data points since the last meeting, which are also heading downwards. We had a period of sickness over 7% from June 2021 to January 2023. And we now have around about a year of under 7% sickness. So that's a significant improvement, albeit based on where we were during a period of fairly extreme pressure during COVID. It is creeping towards our more normalised rates, but obviously sickness of over 6% is still fairly significant. However, it is encouraging that it continues to tick down. So if you look at the graph on page 24, that really does show a significant improvement over the last year. What I think we probably need to do now is reset our targets in light of where we are now. So our target has been a 12-month reduction trend. I think we've achieved that actually. So I think we probably now need to take a look at that, given that we appear to be to some extent at least recovering from our COVID baseline for sickness to re-normalise that. And many of our processes for managing sickness are now fully instituted in a way that they perhaps weren't previously. In terms of nursing turnover, we hit a peak of just over 12% a few months back. We've now again had 4 data points in the right direction. I think that's encouraging, but I think we probably need to wait a little bit before drawing any conclusions on that. We're now around about the 10.7% mark, which is slightly below the UK average, which is about 11%. So yeah, very encouraging, but 11% turnover in nursing is still significant for us. We have 4,000 nurses, so that is a chunky number for us to bring in, linked to education commissioning and overseas recruitment every year. There are a number of initiatives that are happening nationally and locally. I think we need to wait to see the impact of those, and perhaps claiming success at this point would be a little bit premature. So we'll come back to you on that. Also just worth mentioning that we are seeing a continuous uptick in PDR and Stataman training rates, such that we are now above pre-pandemic levels. So if you look at the graph at the bottom of page 24, we're now above the levels that we were in April 2020, which I think is really encouraging. We're not a million miles away from our target on Stataman training, and PDR continues to tick up. If you consider pressure in the system, strike action, the fact that we've had an OCP and various other things, I think that's a huge testament to clinical and operational teams who are continuing to do these things that we know are good for our people, despite all of that context. And then more generally, I think we need to just continue to monitor these very closely. They are not widget targets, they are dynamic. So we do need to keep an eye on them and keep reviewing our practice. And also, as I mentioned, probably in a couple of areas need to just tweak and adjust our ambition in terms of what we're trying to head towards, particularly on sickness as it begins to normalise, but recognising, of course, as I just mentioned, there still is an awful lot of pressure in the system. So we would expect higher levels of sickness, but we just need to keep an eye on that. So I think a relatively positive picture, but let's just keep an eye and keep the impetus up. Thank you.
Thank you, Harry. That's really helpful. Okay, Richie, I'll come to you here next time in terms of the quality items on the
agenda.
Lovely, thank you very much, Chair. So a couple of points I want to bring through from the report. So just recognition of the work being done in relation to governance. So we've seen a reduction in the over 90 days NRI reports remaining open. So the previous period there was 70. So that's as a result of targeted work and intervention from the team. The same team then are achieving the concerns response rate within 30 days, now being maintained over 85%. In the data set, there was an engineered dip in performance, but that was to deal with the backlog. And we now, whereas previously we were seeing complaints over 30 days in excess of 160, we're now seeing below 10. And this is as a result of the work being done within the team, but more importantly, the partnership with our care group directors across the piece. So congratulations to them for that work. That's paying dividends. I think there were two elements I wanted to bring through in relation to where we are concerned about, and as IPC. So the Clostridioides difficile levels at the moment, 35% are hospital onset, with the remaining community. So whilst overall, in terms of where we are in the patch, let's say across Wales, we're consistent, we are concerned about the number we're seeing at the moment, particularly around the community onset. So over the last 2 or 3 years, you might imagine IPC has been very focused on the acute sites for legitimate reasons. We are now at a stage by which we want to look at the community setting. So ongoing at the moment, I'm sure most of you are aware there is a strategic review in relation to infection control services, and that's something that I'm leading on, so that is progressing. But we are also fortunate to have working with us a nurse consultant from Public Health Wales, who will be focusing on Clostridioides difficile and E. coli in the community, working with the care group, primary care community, to understand what's the lay of the land and what can we feasibly do in the early stages in order to understand the picture and provide some targeted interventions ahead of completion of the strategic review, which we're hoping will provide a more robust service in relation to infection control for our community partners. So the same really point for me is on E. coli in itself. So you can see from the data there, so it's a 2.1% increase compared to the same period for 22-23. The same picture that I've described in relation to Clostridioides relates to E. coli. We are concerned about the community prevalence, and that's why we need to target our resources and understanding, and we'll be engaging with stakeholders across the board in relation to that. I finally wanted to pick up or make mention to 3 instances that we're looking at currently within the children and families care group. Certainly wanted to mention that, and if I could bring Carolyn to provide further comment from a quality perspective.
Thank you. Yeah, quality and safety on Tuesday in the in-committee session at the meeting, we were given a presentation, a report on 3 cases in children and family services. We noted the report, there was very detailed information on the cases and subsequent actions, and we took assurance from that as to what was being done. We just wanted to really note our sincere condolences to the families and the relatives of those involved, but also to note the impact on our staff and our concern for them. So that was all duly noted, and that's what I need to say.
Yeah, thank you, Carolyn. Yeah, thank you. Thank you, Richard. And I'm sure on behalf of the board, would echo those comments about our condolences to the families and recognise the impact on our staff. Working in maternity, children and family services are a hugely important part of what we do, and recognising that our staff work incredibly hard in providing an exceptional service, and I know that they would be impacted by those cases that you've alluded to, so it's important to place that on record. So, thank you. Okay. That's it.
Yeah, I've got a couple of questions. On page 7 of 34 of the report on colonoscopy procedures, we're down at 6.8%, and I know you alluded to this, getting particularly about the prevalence of this kind of cancer in this area. I wonder what Cardiff and Vale are doing to have improved their position so significantly, and whether or not we can copy it, given the information that's within that box, particularly under the sustainability plan. It reads to me as if this is going to take an awful long time to sort. So I wonder if we know what kind of Vale have done to see that massive improvement in very recent times. I'll leave that with you for a second. Page 13, red release.
Should come back on first?
Okay.
Yeah, more than happy to. Let's do it. Who's
Yeah, I'm happy. I'm happy to pick that one up. So that's in relation to the timeline compliance with bowel screening Wales patients. We've had a couple of challenges. The first is around the timeliness of referrals into the service. So the clock starts ticking as soon as the patient's undertaken their test. We had a real issue last year and into the beginning of this year of the timeliness of patients being referred through from BSW, which we picked up and addressed with them. So there was a different process running that was hampering the timeliness of referrals in. So patients weren't actually getting to us until a large proportion of the clock had already ticked down. The second bit then is around who can undertake a bowel screening colonoscopy. And we've got four consultants who can undertake bowel screening Wales. And so we have a limited capacity in terms of when we're able to book those in. Hence why we've been focusing on one, increasing the number of our clinicians that are bowel screening accredited, but secondly, about bringing in additional capacity to bring that down. So just to remind board, all the data from the National Endoscopy Programme suggests that CTM is probably 5 to 6 endoscopy rooms short of the capacity it should have to meet the needs of its population. Now, part of that will be addressed with Ladriston Health Park, but there is an interim arrangement. So we've been working. So we've got the mobile unit at Royal Glamorgan, but that isn't accredited for bowel screening. But what we have now secured is additional insourcing capacity at weekends, and those clinicians are bowel screening accredited. So that is what we'll be using to bring that whole waiting time down. And then longer term, clearly we've got the third unit at Prince Charles will open, and that will allow us to, and we're just finalising the plan for this coming year to have a mixed economy of the third room at Prince Charles, and potentially to sustain the mobile unit for a period of time as well. That will allow us to bring the total waiting time for endoscopy down.
My second point was to say congratulations on 100% red release, and noting the numbers have gone up, but still maintained. And I know I've given a hard time on that. Congratulations about you. 2 more points. The unsupported discharge, I know you've Lauren referred to that, so it's sort of changed my question a bit. We're down at 6.5%, I think, and you just said it's a very new service. But how much impact does that have on the long-term health of the patients? Does it contribute massively to their long-term health?
In terms of does a delayed discharge?
The service that's in place now, the early supported discharge, which is at a very low percentage, but because it's just starting, I guess that's the baseline, as you've said. But what impact does it have? How will it change those patients' road to recovery?
So it means that we should be able to shorten length of stay and be able to pull people out so they can have their recovery and their rehab in their own home, which makes a big difference. So it's a specialist team that will support that individual in their home with targeted therapeutic interventions. The challenge that we've currently got is our stroke specialist team numbers are low within the inpatient settings. We've mapped against other health boards, so we know that we're short in terms of inpatient therapists. So having the dedicated team covering the whole footprint will have a positive impact in terms of the outcomes of our patients.
Can I just comment on that? In fact, there is a point as well that you've got to balance that against the length of stay in a hospital. And you don't, much as we try, even if we had, full services, we can't mobilise them anything like you would do if you were at home in any way. So yes, okay, we may not be able to demonstrate somebody, but that has to be better than keeping someone in a hospital bed for an extended period of time. So that's where the benefit comes from.
Ian.
Oh, right. Yeah, couple of questions and one sort of observation, I think. One was a follow-up in Geraint's question, which was about childhood vaccination rates. Looking at the graph there, we're doing better in a lot of Wales. But what I was wondering was, this has been across quite a lot recently. Has that made any difference to the number of parents, I suppose, the children are not going to contact in order to sort of get vaccinated, or is that having no effect? Because it's been in the press quite a bit recently, hasn't it? And they're talking about a potential measles outbreak across Britain and other countries as well. So I was wondering, that's the first sort of question. Shall I ask them all first? And then, yeah.
Perhaps do you want to go, if they're different members of the exec, perhaps deal with that one first.
Yeah, okay.
Yeah, thanks for that.
So have we seen an increase in people coming forward?
Yes.
So the answer is no. I mean, I think if people are worried, they will put their child forward for their standard vaccinations anyway.
Right.
So it's about us going out, as I said before, in relation to Geraint's question. It's about us identifying pockets where there is no uptake and yes, doing targeted mop-up campaigns.
Yeah.
We're also working through primary care to offer it as people come in opportunistically, if you like.
Okay. Yeah, right, thanks. That was the first one. The next one was, I mean, I think congratulations really to everybody in terms of the mental health improvement, because I mean that's quite significant, isn't it? We can see the assessment improvement. Related to that, however, I think there's a graph on page, was it 33, I think it is, isn't it? In terms of therapeutic intervention, that's actually fallen in the same period. So just wondering what's going on there. We see the assessment seems to have gone up, but the therapeutic intervention has gone down. So it's on the same page, both those graphs.
I mean, I think really what happens, and get them correct me if I'm wrong, but obviously we've had a big focus on the assessment. Obviously, the more people you get through the assessment, the next stage is the treatment. So we tackled assessment first because we had a big backlog of people waiting for referrals. We're now into the territory of right now, but now we've got this through the assessments. Yes, how do we make sure the treatment profiles and treatment schedules are adjusted to cope with that influx? It's interesting, actually, it came up on Tuesday at leadership group across all NHS organisations. This is a common challenge now, I think, as well as we've got more and more people coming through these pathways, particularly CAMS and the CAMS route. And there was a lot of discussion about how we could try and work, and this is already something that's being picked up locally with, at least on theirs, with children's work across our patch, but also more broadly about education and health, trying to work in a more joined up way, because a lot of these young people and children are being referred through from schools. And so it's how do we make sure we try and get that whole pathway as efficient as possible. So it's not just getting all people fully assessed.
And I think the other bit to note is that the median wait for the assessment happening is dropping. So whilst we're not hitting the target yet, the median wait for that completion is dropping. So we're on track to improve.
It's great. Yeah, it looks great. I mean, just wondering why that's happening.
Yes. So sorry, Chair, can I just come back on the question as well, because obviously we think of MMR as a childhood vaccine, but if people don't get them in childhood, they become adults now as well, right? So they're often within our workforce as well. So we're doing, and if you look at how the MMR was introduced, obviously it's measles, mumps, and rubella.
Yeah.
Depending when you were born, depends what vaccination profile you received, and so we're doing work with clinical teams. We're starting with PEDS and with accident emergency or ED services, auditing who this is across all clinical services, looking at who is up to date with their vaccinations and doing updates as well. Because obviously, if a member of our staff is exposed, we need to exclude them for 3 weeks. Sorry, apologies. As well as potential for ongoing transmission as well. So we're doing work within the hospital sites as well to make sure that gets up.
Thanks, Phil. And the last one was sort of just a commentary. We did a walkabout with Lauren recently up in Prince Charles Hospital in the stroke ward there. I'm very impressed with the staff. Really good, very positive, and so on. They are working hard though against the environment that they're in, and you can see that straight away. And when you go in there, and I felt sorry for them a bit because of that. But they were so hard working, so enthusiastic. There's obviously the clear wins there. It's an organisational thing. I think how do you change the way that ward operates and how the place they working in. It'd be interesting actually to do another walkabout, but in Princess of Wales to compare the two, because I know in the past the statistics in terms of quality improvement for Princess of Wales were worse than Prince Charles was, and so understanding what's going on in those two areas will be sort of an interesting thing. So I'm throwing that one up to Laura and for a follow-up.
Okay, thank you, Richard. Any other questions or comments for the exec team? I just got one I want to just to flag up. Lauren, I think this one's probably for you as well. Just looking at the percentage of children getting less than 14 weeks for AHP, obviously conscious that the figure that we've reported in this document is at 72.8% compared to 90.9% this time last year. What I'm interested to look at is the overall demand picture, because I'm picking up from colleagues outside of the health board who work in our communities and our local authorities that they're seeing an increasing demand for speech and language input, for example, for young children who are on the verge of going to school, whose speech and language skills are perhaps not where they should be. And I'm just interested, obviously I know we gather this as a percentage of those who've been seen within the 14-week target, but I'm just wondering about the total demand picture and what we have to demonstrate how that picture perhaps looks differently between different parts of our region, because obviously I'm conscious it's probably more significant, perhaps more challenging in certain parts of our region.
Yeah, so you're definitely right in terms of that increase in demand since COVID, particularly children and children's services that are impacted. So I can get some detail on that and put it in the next report.
Okay, that'll be useful. Yeah, thank you very much. Okay. Any other questions or comments? No? Okay, we are going to pause now for about 10 minutes for a break. You can ask colleagues to return at 11:40 sharp, and we'll then go to the second part of the performance dashboard in relation to our financial performance. Thank you all.
Exciting.
Okay, ladies and gentlemen, welcome back to the second part of the meeting. And we'll move on to item 5.2, which is the month 9 finance report. I shall come to Sally first to present the report and ask if colleagues have any questions in relation to our financial performance and our projections for this financial year. And there may well be some questions about the planning now that colleagues are very much involved in to put out robust plans in place for the new financial year, which will be here sooner rather than later. Sally, thank you.
Well, so in terms of our position as at month 9, in month was a £1 million surplus, which is year to date £2.1 million deficit. So we're continuing to forecast a break-even position. That's our control total, which you'll remember was set by Welsh Government back in October, November, or following the additional allocations. So in round terms, we had additional allocations of 72 million, which 51 million is additionally recurrent on us delivering our control total. So against our original 80 million deficit, we needed to deliver an 8 million improvement. So we're doing that and we're moving towards that. There are some material risks that are included in the risks and opportunities table, and at the last PPF we went through those in some detail. Primarily the risks are, this would be described as allocations we've not yet had confirmed by Welsh Government. Those are quite significant. So for example, wage awards are in excess of 30 million and we haven't yet had that confirmed, and real living wage at 4.8 million, again not yet had that confirmed. So those are material risks, as is the potential cost of industrial action. As Jonathan said, we haven't yet got the outputs of that, and I know there's been a lot of chasing around over the last sort of 24 hours to make sure any of the shifts that were agreed for our consultant colleagues are now reflected on Patchwork, which is our automated system, and will allow us to have a more robust assessment of what we've spent. Clearly, we're also assessing the deductions from wages or salaries for staff who were striking. That is run through shared services, who are the single employer in the main for our junior doctors. So that is a further complicating factor in bringing it all together. But we're being chased for figures around that. And clearly, if there's further industrial action, that could also present another pressure that isn't currently reflected in our forecast. The other bit to draw your attention to in here is that the underlying deficit as at the end of 23-24 is assessed at 35.7 million. We will be assessing some of that against the recently issued allocation letters. Positive in next year's position is it does include that conditionally recurrent 51 million. There's also funding for energy, which we were not necessarily expecting to be put forward at 9.7, I think, million. And a number of other allocations which are positive, and an uplift of 3.67 to reflect demand pressures and non-pay inflation. Pay awards will be funded separately. So we are doing a lot of work to try and assess where we are against that and that underlying deficit. The aim is to deliver a plan that's consistent with this year's control title, i.e. break even or better, is what we're being asked to do in order to ensure that those conditionally recurrent monies remain with us. So lots of work to be done to assess all of those, and it will continue to be reassessed over the months. In terms of savings, we are a little below at month 9 in terms of our savings target being 20.5, and we're at 20 million, but significant improvements on year. I think it's about trying to understand the difference between what we've managed to deliver recurrently and non-recurrently in year to support our position, and what we can do to rebalance into next year. In terms of cash, which is probably important to draw your attention to, our cash balance at the end of December was 6.4 million. Forecast cash flow for the end shows a nil balance. We are assuming working balance is cash for both revenue and capital, 11 for revenue, 1.75 for capital. That reflects changes in the levels of accruals that we're holding and creditors. And we're also expecting the cash for those allocations that I've indicated. So significant outstanding allocations around pay. One thing to draw your attention to at the end of the report, therefore, summary page is the capital position. We have a very significant capital programme, the largest element of which is the Prince Charles Ground First Floor scheme. That's been a long-running programme. It is the largest programme in Wales. Mel is nodding because he comes along to our project board for that. And has been hugely committed to that. And that there is good progress, but we have to recognise that it's still a challenge for our colleagues working in that environment. We have been at sort of peak building firm activity on site, so we're seeing over 300 additional contractors on site every day in delivering the schemes, and clearly our services need to work in that environment. You wouldn't necessarily expect to deliver such a major capital scheme in a live hospital environment, so we do recognise the challenges in that, and maintaining the programme on track across a number of years, and then into phase 3, which will be our next business case that we'll see here in a few months, hopefully. It is really important. And then we are forecasting break even for the cash resource limit target. There's a lot of movement in that. We're still having some additional allocations made from flexibilities at Welsh Government, and we're working very, very hard to land that on the nose. Then just finally, just wanted to draw your attention to the second, this month we've introduced an income and expenditure account summary, which Kath, I think we had a detailed discussion about, and hopefully that gives you a good feel of the overall 1.5 billion that we're spending and how it's attributed. So happy to take any questions.
Thank you, Sally. Okay, questions?
Yeah, thank you. I thought it was really comprehensive papers. Yeah, just a quick question around the cash, knowing about the volatilities of cash and why it jumped up so from month 8 to month 9.
It'll just be timing issues in terms of how things work. How some payments go. I mean, our aim is, we don't draw cash. We're not supposed to draw down cash ahead of need. So it is very likely timing issues, but I can share some of that detail. It would be helpful.
Yeah, because it's gone from 4 million to 6.
Yes.
Yeah.
I mean, having come from an English Foundation Trust prior to coming into here, I still find that an incredibly low cash balance if you consider the sort of extent of our overall expenditure.
Yeah, no, agree.
That's it.
Yeah, when are we likely to have this spring really? When are we going to hear from Welsh Government about the allocations and obviously the cash that goes with them?
So I think they are still working through how they attribute the wage awards. There's some work ongoing with our Deputy Directors of Finance with Welsh Government colleagues. It needs to be out really by the end of this month. And some health boards need certainty around the cash. There is some indication that they might do a half revenue allocation and a half cash allocation while they finalise the detail. I'm not quite sure why they would do the revenue part, but let's just park that for the moment. The greater obviously the real living wage, 4.8 million, where I think they're now saying there's significant differentials across Wales. There has been all the way through the year, but that's still, there's some work going on to pin that down. So they said it would be out for month 7. They said it would be out for month 8. They said it would be out for month 9. So I'm still not completely convinced we'll see it before month 10, but we have to see it before month 11.
If all of the details we see here have been included in the narrative that goes to Welsh Government, so they know what.
It's been in the narrative and in the monitoring return template, so it's been absolutely explicit.
Yeah. And I think it's worth saying congratulations on the capital expenditure, because it is such a huge amount of money, and I'm not sure how much people realise how difficult it is to spend capital in the way it's forecast and then hit that CRL at the end of the year, the capital resource limits at the end of the year.
And we've had some change in the team with Rosie moving into the budget and health part. So Carolyn Blockley has stepped in. She's got experience of working in Welsh Government. She was seconded there for 18 months and she's really picked up in terms of you know, just stepping into that role. So that's been positive in terms of just that transition.
Yeah.
But yes, it is complicated. Yes.
It's just an observation, because for us as a board, I'm very fortunate or unfortunate that I've sat with Sally and the team working on the PCH first floor. I don't know, but it isn't just about money. I know we're talking about money now. I'm slipping this bit in now because I don't know where else in the agenda to sort of end choice, Charles. It's about the work that Tilbury Douglas and the health board is doing with the communities. Because it's a huge part of this project. I know we talk about multi-million pounds and all the stuff. But anyway, and I know I can sit on the stakeholder group, and there's 62 contacts we've made now, right? And last week, and I can go to Tilbury Douglas on the 18th, 20th, and 21st. I've got an open doors week, and this is going to schools, to all our partner organisations across the wide spectrum. But 62 different organisations who are engaged in what we're doing on a hospital site. I just think it's fantastic. It's really good.
And I think it does reflect, you know, that we're an anchor organisation that contributes to the foundational economy. So it is very positive in terms of that. And at the end, we will have a hospital that is functional and meets modern standards to a much better degree than where we've been.
And it's celebrated by the community. They feel they've got a part of the actual bill and they're involved in its construction. Thank you, Chair.
I was thinking about, and it does strike me that when you consider, you know, the enormity of the work that Tilbury Douglas and colleagues have done at the Charles Hospital site, you know, spending, as we are now doing, sort of significant sums of money to bring that hospital building into the 21st century. But alongside the ambition of the other areas of work that we're going to be engaged in over the next 12 months, you know, the work being done to repurpose and to reimagine what the Mystead Community Hospital does, the work we're doing around the Clanfriston Health Park. You know, we are constantly in a state of, I suppose, increased demand and pressure for our services. But what's important for us as a health board is also to convey to the public that despite being able to respond to those increases in demand for the services we provide, there is also a huge ambition in the work that we're doing, particularly around our capital estate and what that means for patients and families. And I think, you know, these are, I think, really important examples of the ambition of the health board that's been set, that will be developed even further in this financial year, obviously subject to, you know, business cases from Welsh Government or the RPB or from wherever those resources are drawn. But I think it's really important to, you know, project that message as one of ambition, because very often what people see, sadly, in the news is perhaps the negative side of what happens in health, as opposed to the positivity of that ambition, which is, I think, equally important to project. Sally, a question, just perhaps an observation around the savings. And of course, you know, health boards have benefited quite significantly because Welsh Government was able to identify quite a significant level of additional resource for health boards, which Sally has alluded to in terms of that recurrent and non-recurrent additional expenditure or allocation. But however, it's still worth pointing out the team have been working extremely hard, particularly around our savings target. And I know we're slightly adrift at month 9. I think that itself is quite a significant element. It's times when we are achieving, you know, improvements as getting pointed out earlier on around our performance, dealing with a range of challenges that arise from time to time, whether it's business continuity measures being put in place, whether it's industrial action. You know, the team will be working really hard to identify how to make what we do more efficient and effective, and meeting, you know, attempting to meet our savings target. And I think that, you know, it's not just about being given money and spending it. It is about being more efficient at what we do. And, you know, that requires a huge level of focus, not just by Sally's team, but also by our care groups and others in helping to drive some of those costs down. And I think that, again, that's a really healthy thing for us to be doing as an organisation, not despite the fact that it's not without challenge.
Yeah. I mean, I think it's important, isn't it, that everybody's worked very hard on increasing the sort of savings delivery this year compared to previous years.
Yes.
And we know that fell away really during the COVID years because of, quite understandably, people were focused in a different way. So there's a return to looking at our savings and efficiencies. I think there's a bit as well about the some of the All Wales value and sustainability work that's starting to feed through areas that we need to look at in terms of a savings pipeline, but there's still more work to do. We need to take that balanced approach to performance, risk, safety and finance as we build that programme. Probably worth noting we're just involved in a all Wales audit programme around our savings delivery that Audit Wales are just kicking off currently, and I think Gethin has already been interviewed by them.
Any comments or questions? I was happy to note the report. Thank you very much. We're moving to item 6, our strategic planning, and first up is the development of our acute clinical services plan and an update from Linda. Thank you, Linda.
Thank you, Chair. I'm going to start with a reminder that this is cited within the broader CTM 2030 sets of objectives, and of which there are 3 strategic themes. That of building healthier communities, we just talked about a bit about now. I work to develop more robust and responsive integrated community services, which is a very live work stream. And then this, which is about our hospital services. And we know that all of those are interrelated and you can't do one without the other, but you have to chomp the elephant somehow. So as we've said before, our acute clinical services plan process is undertaking with the care groups a really robust baselining activity, which is really, really, really important to get right. So we need to be really clear about where we are underperforming in terms of indicators and outcomes for our population, as they will become the metrics that have to follow us all the way through the process. They drive any proposals for change, and they're the criteria to assess those proposals for change. We're really clear about what we're having to fix and why and how. We've undertaken a first version of that. We are just going back round again because there is more specificity needed in some of those metrics than we've got at this point in time to really to help us drive the programme. And if we don't get it right, as I say, we need to get it right. So we're doing that now. I just want to come on to section 2.3. Is it 2.3? Has it gone? Let's talk about the maternity and neonates element, because there's a quote in here that's lifted from a WISC report about neonate outcomes, in particular, and the need therefore for there to be a South East Wales review of maternity and neonate services, and that's going to be proposal for that's going back to the WISC committee in March, and it's going to really look at the outcomes for babies across South East Wales and what is driving something of a shortfall there compared to comparable health systems, and what changes need to be made. But because that's happening, the executive made a decision that we won't be looking internally in isolation at our own maternity and neonate services. We will do that as part of that broader process across the region, which I think makes absolute sense. And in terms of comms and engagement, just to say that we are working with an organisation called the Consultation Institute, who act as a kind of critical friend around our processes and what we're intending, what we have been doing, what we are doing, and what we intend to do in terms of working with broader stakeholders. And we continue to keep community leaders and politicians briefed on what we're doing and where we're at in that process. I think if we got some risks, is that there's always the risk, isn't there, around capability, capacity. We've got the right people in the right place to drive the thinking and the processes and the evaluations. So we continue to look at how we mitigate that. So I think, Chair, I'll stop there in terms of what we're doing. I think the next steps are as they are there, and just see if there's any questions.
Thank you, Linda. That's really helpful. Any questions of Kath and then Patsy?
Yeah, thank you, Linda. Yeah, I was really pleased to see that we're going to be looking at accessible language because I just think that's so important in a, with the health board, because we use lots of acronyms and the community, will not understand. I'm still learning in terms of acronyms. So I think having accessible language is really important. So just wanted to say thank you for that. And I think I'm attending tomorrow as well. Just we've got the leaders network as well, which would be really good. So looking forward to that. I was wondering if it would be worth you circulating the spec that you've done for the Consultation Institute. It might be just useful for sort of background information, if that would be possible. And obviously I'm really looking forward to seeing sort of more of the data and the evidence for change as well, when, as this sort of programme moves forward. So those were my sort of brief comments, really.
I mean, just on the point about the data and evidence, we were talking only on Monday as the execs about this, because I think what we're getting, and Linda, correct me if I'm wrong here, but I think what we've got emerging now is clinical perspectives on the sort of clinical rationale for change. I think what we've also got to then make sure is that that is underpinned by some really robust data analysis about, well, if we do move these services around in different ways, are we confident that there will be enough bed capacity? Are we confident there'll be enough physical capacity, people capacity? So I think perhaps the capability conversation that Linda's referred to is probably, it's that capacity to do that really detailed data analysis, because we want to make sure that when we go and talk to communities about changes to services, that not only can we describe the clinical rationale, but we can actually show that we've worked through what the consequential impact will be. And so I guess I don't make any apology for us taking our time to make sure we get all the data absolutely right and accurate before we go and engage and talk about the detail, because I think otherwise history tells us that you come unstuck quite quickly, because people will run a coach and horses through you and your theory if you haven't got the really good data that underpins it. So I think probably we're edging into that territory now, aren't we, where the clinical models are starting to emerge from the clinical teams. We now then need to take those clinical models and work those through with the data analysis to make sure that fits, if you like, where we need to go in the future. So, and also, frankly, it ties in with financial planning as well, because as well as the clinical improvement we want to see through changing the configuration of services, is part of our ambition to create a financially sustainable organisation well into the future. So it's really important that all of those aspects are modeled through, so that we don't create unintended consequences down the line.
Just a couple of points. The maternity and neonates, understand why they need to be together, but it will be CTM leading that rather than WISC leading that.
It needs to be a joint approach between the three health boards. With WISC supporting that as commissioners of specialised services.
Okay, but it's CTM that will have the clinical input, because CTM's got to own this at the end.
Well, I think perhaps it's the three health boards that have got to own it, because
sorry.
but WISC, as Linda just said, WISC only commission a small part of this pathway. And probably it's fair to say, isn't it, Linda, that we've had to try and remind WISC that you can't just look at the very specialist neonatal bit and come up with views of how you reconfigure that without the implications for the rest of the maternity and neonatal services. So hence that's led to the point of saying, well, if that's the drive to improve the very specialist end, we collectively as three health boards need to have to your point, we've got to be driving what the whole model looks like. And I think, as Linda's highlighted, this is something where we couldn't really look at maternity and neonatal just as CTM, because we are independent with Cardiff already for specialist services. But looking to the future and the use and to try and meet the standards that are set by professional bodies for maternity and neonatal, there is going to be a need to think about, particularly the higher end of those. How do we work it even more in a joined up way? So you're absolutely right. It's got to be driven by the health boards. WISC have a view from the very for a sort of small percentage of that work, but the bulk of it would be a health board led programme.
And just one more point, are we including South Powers in this? Because the maternity and neonates, the South Powers is an better than CTM.
The flows of powers are a really significant driver for what the outcomes of a review might be.
Yeah, I think Paul's right. I think the key risk with this is how we articulate all this to not just our own staff, but the communities, politicians and so on. And as we've seen in the past, things can go wrong if we don't do that right. And data is key. But you know, that's the more detailed analysis. But I think it was mentioned earlier on, and we mentioned it in the previous boards as well, that we do need that almost 101 plan. I was going to say for dummies then, but that's insulting to say for dummies, isn't it? But you know what I mean?
Yeah.
We need that sort of almost like graphical book with maybe not a book, but web page, whatever, with lots of pictures and easily accessible information for everybody in the community, so they can understand quite clearly what we're doing. Then if they want to look at the detail, then they go into all the stats and whatever.
Yeah.
But for the upfront thing, I think is really important. Yeah.
Thanks, Ian. Linda, just an observation. And it is particularly around how those clinical models are then tested and where we ensure the robustness of that, and how that translates down into the messaging that builds the public facing document. I know we've got a timescale that we set out as a board. Can I say that you know, as chair, I am more than happy for us to be more flexible if it means that we can build a bit more time in if needed to assure ourselves that we've got everything in the right shape and that the language and the messaging is done. But I would rather have that in that way than us feeling, oh my goodness, we've got a time scale. Therefore, we said we'd do this at this point and this at that point. And I would rather that than, I'm not saying it is being rushed, but clearly I know with the timetable then people think, oh, that is the absolute necessity. And for me, it is about landing this in the right moment. So just, I think as chair, I would be more than happy if that time scale is flexed to support the work, because this is a large piece of work. I've got another point in my book. Carry through.
Sorry, I haven't said much today, have I? I just wanted to check in terms of if you're making clinical models now and engaging with the public later on, I just wanted some reassurance that whilst you're developing and storming now, that there's a patient voice in that, or so you've got the expert patient in each clinical area. Is that how you're doing it? Or?
That's how we will do it. We haven't got to that stage yet. The point of the discourse is letting the public know that we're looking at making changes, and there's a kind of arc to that of developing option, talking to our clinicians, developing options, and then evaluating those. A lot of these services, a lot of the drivers for change are at the very, very critical end of care. I don't know how to run an ITU. I need to talk to the doctors and the nurses and the therapists in the ITU first to understand what the issues are. And we're still at that stage. We're still at the baselining stage of saying, tell us what the issues are for you in terms of being able to meet these standards. Then as we get into each of those services where we identify that there are some critical things that need to be fixed, clearly that then is a discussion with a broader set of stakeholders as well. So thank you. And then any changes have to then also go through, as we would want to, a wider engagement and a formal consultation. So there'll be plenty of opportunity, but I completely agree that getting the patient perspective in at the beginning when we're looking to make a change is really key.
Or when you're deciding what that change is, I think it's important, because if you can't get the lived experience of the patient when you're, it's all well and good having the clinicians and the nursing team saying what the problems are, but you need that patient voice in the middle of that as well.
That's what I meant.
That right at the beginning. Thank you.
Well, just follow on from that. I think it's probably also worth reminding ourselves that in some ways we're having to do a bit of an internal consultation first, because let's be honest, we've got different parts of our organisation that haven't been used to working in a joined up way across the 3 sites across CTM. So I'd probably say at the minute we've been doing a bit of that, bringing all of our own clinical teams together, because frankly during COVID nobody had any of that time and capacity to do that. So I think probably our priority at this point has just been getting all of our clinical teams together, because let's be frank and honest, even say 10% at ITU, there were different views between the 3 different ITUs about what they wanted to do. So we had to get them all. It wouldn't have been great to be involving patients and then having a whole internal machinations back and forth. But I think you're absolutely right. There's different levels we need to engage patients and communities, because with the best in the world, some patients have particular interest in some areas and not so much of an interest in another area. Some people have got an interest in general healthcare issues. So we've got to try and pitch the right right messaging, the right engagement with the right groups of people at the right time. But I think part of what we want to try and do with the Consultation Institute as well is also make sure that we've got clear strategy for how we're going to do that at every stage in the process, that both at the granular sort of clinical service level and the bigger picture stuff.
Thanks, Paul. Linda, just one final observation from me, and it's actually to do with the front end of the update report, and you made reference there to the strategic themes within CTM 2030, which is building up the communities, integrated community services, and the acute clinical services pack, and the importance of the three. So that when we are talking to our patients, our clinical staff, our stakeholders, the acute clinical services plan is a major plank of our work, but it is so incredibly linked to all of the other work that we're doing. So whether it's the work being led by Philip and his team and our colleagues in primary community care around building those healthy communities, thinking about what primary community care services look like, and attempting to address the point that, in essence, whilst we will be having a discussion about what services we are delivering, and in essence, what the patients end up asking, which is where are they going to be delivered, it's also about what is it that we're currently doing in our hospital environment that, quite frankly, could be better done somewhere else. Now, and that is part of that broader conversation. So I think setting it in the strategic way, I think, is really helpful. But I think it's to remind people that this piece of work is not being done in isolation, that is part of a much bigger package of work that's being led on by several different people all at once.
Yeah,
So,
and I think I think that's, sorry, I'm jumping in front of you. I think that's where we are with it, though, isn't it? It's that when we've gone to the acute sites, we've said this is one of three strategies. You need to start thinking the other way. The problem is that we're all naturally dragged to acute sites. As I would think, I think of healthcare, everyone thinks of the shiny hospital, which is completely the wrong way, because that's only 20% of the care that we deliver is in that site. So we are getting that message across. Sorry, Linda.
No, that's really helpful, Dom. And part of what we do is to continue work to try and challenge those assumptions. I think where we've got a bit of a deficit, if you like, is in people's imagination of how things could be different. Because actually, if you look outside of Wales, outside of the UK, you see some really radical examples of shifting care out of hospital. And we need to be able to kind of inspire people a little bit more in terms of what the art of the possible is.
Thank you, Linda. Thank you. Okay, the report is just for noting, but thanks to your colleagues for their contribution. If we just move to item 6.2, which is the integrated medium-term plan update. Again, there's a report for noting. Linda, anything to add?
I guess this paper, is a formal paper that sets out the requirements, the guidance, the financial kind of guidance, which Sally's already covered. And I guess the thing that I would add in here then is our work with the care groups to establish their plans for next year, which frankly is one on how do you make savings. And we're not looking for business cases, truth be told, because the size of this challenge is such that our priority is to work to make things as cost effective as possible, to bring us into that financial balance. I think they've done a really great first stab where they're going around it again, where some are further on than others. And I guess we, will want to just work out through for ourselves. And we've got a further briefing for IAMS on the 7th of February. And then we've got an extra special PPF, which is Planning, Performance and Finance Committee, on the 13th of March, so that you have two opportunities to understand and then direct some of our decisions about some of those kind of about the plan and whether we're comfortable that we're sort of, there's something to me about balancing the short term and the medium term, and I think there'll be a couple of things that we'll want to talk about in that space. So I think because clearly we need, next time we come back around this table, we need to be signing off the final plans. So it's really important that you have that input. The important thing about the 7th of February, by the way, is that it's a week before we have to get if we're not going to submit a balance plan, we have to make that decision in order to write the accountable officer letter. So that's, but, notwithstanding what Sally said about the importance of a balance plan and, cash limits and things. So, there's some difficult things to balance, I think. As ever.
Thank you, Linda. It's really happy. Any questions? Yes.
Yeah, thank you. I think really helpful and totally understand focusing on the shorter term in terms of sort of next year. I was just sort of reread paragraph 212 again, because obviously that was around our financial duty, and just trying to get my head around that in terms of the financial year. What I didn't see in here was any intention around where we're going for 25, 26 and 26, 27. I'm assuming our intention is to have a break even, but the paper doesn't actually comment on those 2 years. So I was just wondering, when we do have sort of future sessions, whether we are going to sort of at least have a superficial look at what our intentions are for those future years. Absolutely understanding devil's in the detail, and it's all going to be based on lots of assumptions. But coming from a sector where we've had to do 30-year business plans, do you know what I mean? Sometimes you just have to make assumptions, don't you? So
yeah, and I think as we look to next year, and noting that £51 million worth of money is conditionally recurrent on us delivering this year and now next, there is quite a need to look at how we can deliver a balanced plan, but also recognise the other risks and manage that and continue to make positive changes around performance. So there's a lot of work to do, but with £51 million contingent, I think it is. If we deliver a balanced plan this year, then we should certainly be aiming to do that for next. I think, as you say, the 2 following years, we're still in that cycle of what will whole UK position look like, what will the resource allocations look like. But certainly for next year, Welsh Government has signalled very strongly there will not be a repeat of this year where in-year allocations were made, because there's nowhere for them to take that from. And so that's why they are sort of going to enforce the sort of financial disciplines to a greater extent, and expect to see the savings through value and sustainability work tracking through into our plans.
Any other questions? No? Okay, thank you. We'll again note the report. Thank you, Linda. Thank you, Sally. If we can move on to item 7, governance risk and assurance item. And first of all, we normally do incorporate an update on the escalation status. Obviously, Paul has incorporated that in his report, so I don't propose to broaden the conversation any further, because we have managed to touch on that in Paul's Chief Exec's report. So item 7.2, the board assurance framework, and I'll ask Gareth just to present the update report. It has gone to the executive leadership group. It went on the 15th of January, and it's before the board today for approval. Thank you, Gareth.
Chair. Yeah, so in terms of the latest update against the board assurance framework, just to remind everyone that our assurance framework is underpinned by the more detailed organisational risk register, which is obviously considered at the Audit and Risk Committee, and as appropriate at other committees as well. The updates to the strategic risks outlined in red text. I just want to draw members' attention to two substantive updates. One against strategic risk number 3 around our finance, revenue and resources. In Sally's finance update, Sally mentioned that we are projecting a break-even position against our control total. Therefore, the likelihood of that risk crystallising has reduced. So that's been reflected against strategic risk 3. And the other update is in relation to strategic risk 5 around community and engagement. And again, we've done some updates there in recognition that we now have strategic risk number 10 around population health, to just eliminate any duplication there. So making it clear around the description of that community and engagement risk, and the ownership transferring from the Executive Director of Public Health to our Director of Communication, Engagement and Fundraising. And that was all I'd like to say in terms of introducing the paper and future. Thank you.
Thank you, guys. Appreciate it. Okay, any questions on the report? Okay, thank you very much. Can I just ask colleagues to approve the board assurance report in front of us, Sophie? Thank you very much indeed. Okay, we're going to move on to the board committee and advisory group highlight reports. Again, just to remind colleagues that these have been included on the agenda as there are matters included that require escalation to the board, and it is of course the board's way of just having that touch point with committees that need to raise specific issues with us. So we've got the clinical advisory group highlight report in Sally's absence. Dom, if I can come to you to
Certainly. So the clinical advisory group is one of our statutory groups, and it's a collection of individuals across all clinicians are represented on this particular group, and Sally Bolt happens to chair. I take it as read that you've seen this. There are three things I just want to put out directly to you. Actually four, sorry. They did talk about the clinical service plan and how the fact that we've had a meeting with consultants specifically about it, but we haven't had a discussion with other groups as well. Actually, I'm glad it came today because on Tuesday, Linda, Lauren and myself met up with the therapists, the physiotherapists, and with the healthcare scientists as well, and gave exactly the same presentation that we did to the consultants, and had started a discussion with them about the future plan and the future strategy and the whole thing. So they raised that as a concern. Actually, we've dealt with that one already, and there's a similar one for nurses coming up very shortly as well. So by the time we have the next meeting, we'll engage with all clinicians across the health board on that. Other thing that they point out here is this has come up a couple of times, so we're getting about the clear reporting structures, about who do they go to when they've got a problem, and we have a definite plan for that as an organogram when we have all of our new, the OCP is fully completed and we've got the CDs in post. We can publish a health board wide organogram of who's in what role, and everyone will know exactly who they've got to go to at what point. We're holding off sending that out. We don't just, the problem you send one out, you then want to update it sort of, within a few months, you'll get confusing as what things are. So we haven't got that in plan. They wanted to flag what Lauren already told you all, that we are the first health board to have a clinical director for healthcare scientists, and they were exceptionally proud of that. And the other thing that they just to raise on here, that we did have a group underlying them called the clinical sounding board, which fed ideas and discussions, and that was open to every clinician, everyone on the front line across the health board. And we paused that on CAG's advice because attendance was pretty much the same two people out of our whole organisation turned up. So we've tried various iterations of this, of how we engage with them, and everyone seems to start well and then disappear off very, very quickly. So we're going to look at how we go about rebooting that again for, I think, about the fifth time. I think it's important that we have to do things to engage, or we want to do things to hear from our clinicians on the front line, to know what the issues are and concerns that they've got. But we haven't obviously got that magic formula quite yet. So that's just something that can go worrying about and coming up with solutions for. That was it. I didn't want to raise anything more. Chair.
Thank you, Don. Any questions to Don on the highlight report? No? Okay, thank you very much. We'll note the report. Moving on to item 7.3.2, the Planning, Performance and Finance Committee highlight report. Patsy, I think you're going to provide an update on the meeting that was held on the 11th of January.
Yeah, most of what I've written down has been said, mostly by you.
Sorry, Patsy.
It's clearly a positive escalation around CAMS and around mental health. All the details we've heard and we've seen in the report, so I'm not going to repeat that. And I was also going on to say it's pleasing to see finance being reported in the green assurance area. And all my notes say it's huge thanks to everybody across the organisation. But it's not job done because we've still got an underlying 35+ million deficit for next year. So we just need to both keep the focus on this year and then ensure that focus is maintained. But it's huge credit to everybody, both in finance and right across the organisation. Which is almost word for word what you said, Jane.
On the same page.
Yes.
Thank you, Betsy. Any questions to Betsy on the hello? No? Okay, we'll note the update. Thank you very much indeed. Item 7.4 is our section on working in partnership. There's nothing for me to raise under that item on this occasion, unless some colleagues in the exec team have got anything you want to flag. No. Item 7.5, the Audit Wales structured assessment of 2023. Good to see Sarah, I believe, from Audit Wales with us this morning, along with Darren Griffiths. A very warm welcome to you both. I'll ask Sarah and Gareth just to present the report, and I'll ask if colleagues have any questions. So good morning both, good to see you.
Good morning, good afternoon, sorry, thank you, Chair. I was just going to provide a brief overview. I will take the report as read for members. So overall, this is a positive structure assessment report, and it does demonstrate an organisation that's clear on its direction and has good planning arrangements in place. There's strength in the executive leadership and a real collegiate approach as well. The board and the committees operate effectively and cohesively, and risk management arrangements have continued to strengthen, with the board assurance framework operating well as those support and risk management arrangements in place as well. Planning arrangements have matured, with work underway on the clinical services plan is positive, and we've seen obviously updates on that today. And we can see a clear direction of travel with the health board vision and strategic goals as well. In terms of the financial resources, there's a consistent theme across the structured assessments, as you would expect, and Sally's already highlighted the work that we're doing on financial efficiencies with the health board at the moment. We did feel that there was a clear process for financial planning and as well as monitoring as well. We've made 6 recommendations in total, and we've got an agreed management response to this as well. And I just want to take this opportunity to really thank the health board for their continued support and engagement with this work, particularly noting the corporate governance team and Gareth and Callie as well. So I'm happy to take any questions on the report as it stands. Thank you.
Okay. Colleagues have had time to review the report and the observations and findings. Any questions? Observations?
Just a comment, Jonathan, to say this was thoroughly scrutinised both in a specific meeting about this and also through the audit committee, where some considerable time spent going through it. So that's all.
Okay. Just a quick question to you both from me. Knowing the volume of work that Audit Wales are involved in, and obviously the requirements placed on us as a health board as part of the engagement to helping you to pull together the structured assessment, when does at what point in 2024 do you start planning for this year's structured assessment?
Well, I mean, it's structured assessment is an ongoing process, really, in the sense that, we are always capturing information. We're in a position at the moment where we're starting to think about risk planning for the audit plan that we would be taking probably in March. So, structured assessment is an ongoing. I've obviously been noting things as they kind of go forward from this point. So, yeah, structured assessment is a continual process, and we'll pick up information as we kind of go through. But you will get your audit plan as well. Financial efficiencies will obviously feed in as well. So there's lots of pieces of the work that we kind of draw on.
Okay, unless there are any questions or comments, are colleagues happy to note the update provided? It's just to board for noting today. Yes, okay, thank you very much. Thank you, Sarah. Thank you, Darren. Good to see you both this afternoon. Much appreciated.
Thank you.
Thank you.
All the best. Bye. Item 7.6 has been dealt with. If we can move to the item 8, to the consent agenda. There are, just to deal with matters separately, there are those matters for approval, which are items listed 8.1.1 through to 8.1.6. Can I just ask if colleagues are happy to approve all of those on block, on the basis that nobody asked for any matter to be brought forward to the early part of the meeting? Thank you very much. And for those items to be noted, item 8.2.1 all the way down to 8.2.2. So there's 2 items today. So just 2 items for noting the forward work programme and the committee advisory group highlight reports which we've had. So just to formally note those, thank you very much. Just to say, under item 9, I've not been notified of any other business for today's board meeting, so there's nothing I intend raising at this point. Under item 9.2, again, just to remind colleagues, in terms of assessing our effectiveness as a board, obviously I am keen to hear from colleagues, put forward any comments on how we can improve our board meetings as we go from one board meeting to the next. If you could come back to me or to Gareth and the governance team on our board meetings, if there are things that you think we could deal with differently as a board, if there are items you think could be revamped or revised on the agenda, if you think some of our timings might go a little bit skew on occasion, all positive feedback is welcome, and any negative feedback as well. So, but it's really important that we reflect on how we conduct ourselves and how our business is transacted. So, perhaps over the next couple of weeks, give us a thought. Any feedback, please let me know. Item 10, there's nothing requiring an in committee discussion on this occasion, but we'll retain this item on the agenda just because it's useful if we do need to feed back to formal board on any in-committee sessions we might have had as a board. Item 11, date and time of the next meeting. We are meeting in public as a board on the 28th of March, commencing at 10 o'clock. Just to flag up, it is Monday, Thursday. If there are any early apologies, please let me know. It is Holy Week. Some people may not be around on Monday, Thursday, but if that causes anybody any difficulty, please let me know, and we'll attempt to address that. Just to remind colleagues, we do have a board development session which will be in February. So just to keep an eye on that, because we are looking to make better use of our board development sessions as we seek to align those update and rather really informative sessions to ensure that they align with CTM 2030 and the work of the board. So the one feeding more naturally into the work of the board in its public sessions. And again, just to remind colleagues that the board development session that will take place in April, which may seem like a long way away, but it really isn't, is going to be a joint session with Public Health Wales. As you know, I've been very keen for us to do more work with Public Health Wales. It follows on from Janet Williams and colleagues from Public Health Wales attending a previous board development session on type 2 diabetes. I think there's a great opportunity for us to do more work with PHW, as the organisation that takes that strategic lead on public health matters. And I know that Philip is working very closely with their team on a range of issues. So we have that in April to look forward to. I think that's a really healthy thing for us to be doing as a health board. Rydyn dod y gyfarfod y bodd Iechi Ben, hoddi'n y diolch y bar sydd wedi ymuno i ni gwylio y gyfarfod heddiw. I now bring the board meeting to a close. I'd like to extend thanks to all those who participated in the meeting or observed our proceedings today. And that concludes our board session. Thank you all very much indeed. Thank you.